Hello, my name is Benjamin Newman. I'm a fourth year pharmacy student, and today I'm going to be discussing a pharmacy student's guide to pain and pain medication management. So let's get started. In terms of our outline today, I'm going to be talking about what pain is and give a brief definition, as well as talk about some of the common types of pain we see today. We'll follow that up by discussing some of the medications that we see most commonly used in practice today, with a special emphasis on the use of cannabis for pain management. And we'll wrap it up with a conclusion. So I thought the best place to start would be with the definition. According to the International Association for the Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It's also important to realize that most pain has a purpose. Specifically, pain alerts us about a particular problem. It helps protect us from further injury by causing a reaction to the pain, causing us to withdraw, and it also helps to facilitate healing. Pain can be broken down into two basic general categories. First is acute pain. Acute pain is defined as that of recent onset and usually has a short duration. Additionally, acute pain usually has a known cause and it serves a protective role. On the flip side, we have chronic pain. Chronic pain is usually that of long duration and persistent. It usually doesn't have a known cause, and it is pathologic, meaning it serves no biologic function. Additionally, chronic pain is often associated with a strong psychological component as well. These pain categories can be further broken down. Acute pain can also take the form of nociceptive pain, which is pain that is evoked by a high intensity stimulus, such as when you stub your toe. It can also manifest as inflammatory pain, pain that is brought on by inflammation. So you have pain in adjacent tissue to the tissue where damage occurred, and this serves a protective function. On the flip side, we also have dysfunctional pain, which is pain that is experienced without a stimulus and is not due to nerve damage or to peripheral damage. We also have neuropathic pain, which, as the name implies, is pain that arises due to damage done to nerves. Additionally, it's important to realize that acute pain can transition into chronic pain if it's not treated properly. In terms of our goals for pain management, we aim to reduce pain by about 30 to 50%, and it's important that clients or patients are aware of this to keep expectations realistic. Additionally, we treat pain to help improve function and improve quality of life. We also treat pain to help prevent that acute to chronic pain transition, and our focus is on holistic pain management. This is done by various methods. We can treat pain using physical therapy, cognitive behavioral therapy, which is especially useful for chronic pain, and of course with medications, which we will now transition to discuss. The first medication, and should come as no surprise, is acetaminophen or Tylenol. This really is the workhorse of pain management. Acetaminophen is an analgesic, meaning it helps to reduce the pain stimulus, and is also an antipyretic, meaning it helps to reduce fevers. Acetaminophen has been shown to be useful in the treatment of mild to moderate acute pain. However, we also see it employed frequently for chronic pain, although the evidence for benefit is somewhat limited. Acetaminophen is very well tolerated, and so we often see it employed first in most cases of pain relief. The next class of medications I want to discuss are the NSAIDs, or non-steroidal anti-inflammatory drugs. This includes medications like diclofenac, ibuprofen, naproxen, among others. Like acetaminophen, NSAIDs are analgesic and antipyretic in nature, but they also have the added benefit of being anti-inflammatories, although their true anti-inflammatory effect isn't manifest unless they're put at relatively high doses for extended periods of time, usually about 5 to 7 days. NSAIDs have been shown to be quite effective in the treatment of mild to severe acute pain, and are additionally also first-line agents for treatment in chronic low back pain. Unfortunately, unlike acetaminophen, NSAIDs do come with some adverse effects. Specifically, they have various gastrointestinal side effects, which includes ulcerations and bleeding. And they can also have various cardiovascular effects, such as increasing blood pressure. Because of these adverse effects, oral analgesic NSAIDs are usually recommended against in older adult patients because they are more sensitive to these side effects. That being said, the topical agents like Voltaren gel are very commonly used in older adults because of their low side effect risk. Next, I want to talk about a couple muscle relaxants. So the first one we have is called cyclobenzaprine, which we see commonly in practice, used for the treatment of acute back and neck pain and various other muscle pains. Cyclobenzaprine is usually only recommended to be kept on for a short period of time due to its adverse effect, which is causing quite a bit of drowsiness. Because of that, we usually see this medication dosed at bedtime. The next medication is baclofen, which is also a muscle relaxant, but it usually is employed for the help of neuropathic pain. Again, sedation is common with this, so it's important that patients are aware before this is prescribed. There are many other kinds of pain medications that we use today. Firstly, we have antidepressants, specifically duloxetine or nortriptyline, which have been shown to be quite beneficial in chronic pain management. Additionally, some antidepressants are also first line in the treatment of neuropathic pain. Next, we have the gabapentinoids, specifically gabapentin and pregabalin, which also have been shown to be quite beneficial for the treatment of chronic pain and are also first-line options for the treatment of various types of neuropathic pain. We also have anti-epileptic medications, which we do use on occasion for the treatment of various types of neuropathic pain, specifically trigeminal neuralgia, with the most common one being carbamazepine. And finally, we have miscellaneous topical agents, specifically lidocaine, which is a topical anesthetic, and capsaicin, which is the chemical found in spicy chili peppers that gives them their heat. Both of these agents have been shown to be beneficial in the treatment of various types of neuropathic pain, like I mentioned, and lidocaine is actually a first-line treatment option in older adults suffering from neuropathic pain due to its relatively low adverse effect profile. With any of these oral agents, sedation and dizziness are incredibly common, so it's important we start at the lowest possible dose and titrate up, both for effect and to reduce potential for adverse effects. Of course, no discussion on pain management would be complete without also discussing opioids. So we have many different opioid options, commonly including morphine, codeine, hydromorphone, oxycodone, and fentanyl. Now, many of these work the same way. The main difference is found in their potencies. As I'm sure most of you are aware, there are inherent risks with using opioids. Specifically, long-term use of opioids can cause dependence on their use. And people can also get tolerant to the use of opioids, meaning the pain is not as well controlled on doses that they were currently stable on. So what often ends up happening is doses are increased, which can lead to further issues. Additionally, people on long-term opioid use can experience withdrawal if doses are cut back or stopped entirely, which is a whole other host of issues. Additionally, opioids can also cause drowsiness, dizziness, and altered cognition. Now, these specifically occur if doses are started too high or if patients are opioid naive. That is why it's important to start opioids at the lowest possible dose and increase doses very slowly and gradually as tolerated. Additionally, people on long-term or even short-term opioid use can experience constipation, and this can occur regardless of how long a person is on opioids. It's important that patients be made aware and appropriate methods taken to avoid this adverse effect. In terms of the research, opioids have been shown to be most beneficial in the treatment of dysfunctional pain. However, they can also be employed for neuropathic pain, although they don't seem to be quite as effective. Additionally, we have two other opioids that I wanted to briefly discuss because we're starting to see them more in practice today for the use of pain treatment. The first is tramadol, which is a synthetic opioid, and it has fewer adverse effects compared to the more typical standard opioids you would see in practice. It has a lower risk of dependence as well as tolerance, and similar with Suboxone as well. Suboxone is an opioid and opioid antagonist combination and kind of acts to reduce that risk of dependence with the medication. So leading off from here is a good time to bring up cannabis. So what is cannabis's role in the treatment of pain? Before we jump into that, I think it's important to get a basic understanding of what cannabis is. So cannabis is a plant, and it's among many other components, its two major components that we want to look at today are THC and CBD. So THC is the psychoactive ingredient in cannabis and is responsible for the high. It also plays a role in pain modulation as well. CBD is non-psychoactive in nature and also plays a role in pain modulation. However, importantly, it also helps to antagonize THC, meaning it can reduce the psychoactive effects that THC produces. In terms of medical grade cannabinoids that we have available today, we specifically have Nabilone, which is a synthetic cannabinoid, and we also have nabiximols, which is a 1-to-1 ratio of THC to CBD. In terms of the general risks with using cannabis, we see most often dizziness and drowsiness with a number needed to harm of only 5, and altered mood as well, which includes things like euphoria, that high sensation, and also anxiety with a number needed to harm of 4. There are some benefits to using cannabis over other medications like opioids, specifically because cannabis has a much lower risk of dependence compared to opioids, as well as a low risk for withdrawal if cannabis were to be stopped. Additionally, cannabis use has very few serious adverse drug reactions. So is cannabis the miracle drug for the treatment of pain? Well, let's take a look at some of the evidence. In regards to non-pain uses for cannabis, there is moderate evidence to suggest that cannabis is effective in the use of chemo-induced nausea and vomiting and reducing that effect. And also it has been shown to be beneficial to reduce spasticity in multiple sclerosis patients. Now, what about pain? Well, cannabis has actually been shown to be useful in the treatment of neuropathic pain. In fact, in the pain treatment scale, cannabis options are usually listed as third line in most guidelines, and they have a modest effect as an add-on agent as well, with various studies reporting a number needed to treat of 11 patients for 4 weeks versus placebo. In other words, if we treat 11 patients with cannabis that suffer from neuropathic pain, one of them will experience a benefit after about 4 weeks. So this is a meta-analysis that was done on the 2 medical grade cannabis products that we have available, and they plotted the results in a forest plot. So on the top, you can see Nabilone with a few different studies that were done and the pooled estimates were taken. Now, the studies compared the use of cannabis in improving pain on an 11-point scale. And in the Nabilone group, they showed that the benefit was non-significant in nature. As you can see, the large black diamond crosses over the center line. However, it does seem to have some numerical benefit. Looking at nabiximols on the forest plot at the bottom, you can see that the black triangle and the pooled estimate does not cross the line, which means that the results were significant in its effect on pain treatment. However, it seems to only reduce the pain on a pain scale of about 1 point, which is a relatively small number numerically. Now, what about cannabis in other forms aside from the traditional medical cannabis we have in practice today? Unfortunately, we have limited poor quality studies to support other forms of cannabis use. Specifically, one study looked at vaporized cannabis for the treatment of chronic pain, and while it did show benefit, their duration was only 5 days, and their number of participants was only 21, which is quite a small number. Additionally, another study looked at smoked cannabis for neuropathic pain, and their duration was only 1 day. Although it did show benefit, their number of participants in the study was only 38. So again, some poor qualifiers here. Additionally, for topical cannabis for pain management, there have been no well-designed randomized controlled trials that currently exist. And there are additional problems with the current studies that do exist, including them being unblinded or having no control group. Additionally, some of them report subject outcomes or no adverse drug reporting. So clearly, further research is needed in the area of these other forms of cannabis use for the treatment of pain before we can start recommending them to patients. Again, at the end of the day, patient preference has to be taken into consideration. And knowing that there are relatively limited adverse effects with cannabis use, we can certainly take patient perspective in mind. Some other concerns with non-medical grade cannabis include variability in the THC to CBD ratio. And of course, as you remember, the more THC there is in a product, the more psychoactive effects there are. So we really want to limit the THC content and have a fairly equal ratio, which can be tough when many of the products on the market are less regulated than the current medical grade products. Additionally, few, if any, dosing guidelines currently exist for cannabis of non-medical grade quality. Additionally, there was a study published in the journal JAMA by CannaSafe, which was a California-based study that tested blindly 20 popular CBD products. And unfortunately, they found that only 3 of those products contained the ingredients that the labels indicated that they did. About 8 of those studies contained less than 20% of the amount of CBD labeled, including 2 that contained no CBD at all. So it certainly is an issue today as well. And like I said, we go back to patient preference as well. So just to wrap things up in conclusion, pain is both a physical and emotional experience and should be treated thusly. It's important to realize that acute pain can become chronic pain if acute pain is not treated properly. However, we have many different treatment options available to treat the various different modalities of pain that we experience today. Additionally, I hope you understand that cannabis does have its place in pain management today, specifically in the treatment of neuropathic pain. However, that is specifically for medical grade cannabis, and it has been shown that other forms of cannabis have relatively quite poor evidence available. However, it's like I mentioned, it is important to keep patient preference in mind. And if patients are willing to try medications, it's important they know the risks as well as the potential benefits before starting anything. More evidence is definitely needed in the area of cannabis research for pain. So that does it for my presentation today. I hope it was informative, and I hope that you were able to use this information in your practice. These are my references. Thank you for listening.